Previously, in area of CAR T, for those of you who were not aware, we actually had treated 2 patients in Morocco that were late stage pancreatic cancer patients. To my knowledge, to this day, about 10 months later, these patients are still alive, and we have really seen some reduction in their tumors. With that, I'm going to hand up the microphone remotely to our friend, Dr. Antonio Carrasco. Please help me welcome him.
Okay, good afternoon. This is Antonio Carrasco, broadcasting from Lima, Peru. First of all, I want to thank you, all of you, send the organizers, for the invitation for this 4th so-called meeting. I'm really happy to join you, and sorry for the time. I didn't make the agenda, so after lunch is not my favorite time to make a lecture, but we can have a really nice presentation and show you how the CAR T is moving in the field. So this is my name, Antonio. I am a hematologist. I did my specialty in Peru and then moved to MD Anderson for some time and come back to Peru working in the clinic part, doing transplant and other fields on hematology, working on malignancies, on the hematology malignancies, and also working on new strategies as immunotherapy and other combination to treat and try to deal with this heavily complicated disease. This is my disclosures. I did some activity in bio-sharing pharma many years ago, working in Lima in my company, doing some research on cell therapy, and a speaker from other companies as well. So cancer immunotherapy is not new. There are some different ways to move the immune system and go into tumor. There has many approaches. Some others are really still success. Some others are really new. Some others are utilized as a combo and a mixture of different strategies. So as you can see here, the NK-mediated cell cytotoxicity, the T-cell mediated cell cytotoxicity, the ADCC, the macrophage, and the complement mediate. All are strategies that we are using to try to kill tumor cells, as well as the last new kid of the block, which is this engineered T-cell, which is called the CAR T. So what happened, the CAR T, and what is the basis for the cell therapy is that in cancer, we are capable to do expansion, memory, and specificity for the treatment of the tumor cell and the tumor type, trying to do some immune system stimulant and increase the immune system against the disease, and acting this as a live drug. All this induce and produce an active as personalized medicine. As you can see in this cartoon, the T cells, and I'm gonna be a little bit going through the point because I'm happy Dr. The previous speaker, Dr. Hisham, also maybe talk about this, and sorry if there are some other overlapping. We learned that the TCR, which is the T cell key, we are now using the CAR T, and you made the comparison. What is the TCR structure? It's very complicated. Different subunits. Also, it's specificity. What is the CAR T? Oh, sorry, the vector of the CAR T. There is huge difference, but it works. You will see in this movie how this in vivo, you can see the difference of this procedure, how these cells are in the process. Sorry, how it's moving now. How you in vivo can put together the tumor cells and also the CAR T, and you can see how the tumor cells can be destroyed and induce apoptosis and keep the cells going and trying to control the disease. So what happened is the CAR T, and going through the point, the CAR T are quite different. Some companies have produced, as Sky Pharma, Novartis, and Jung with Celgene, some structures we call first, second, and third generations CAR T, all shows different properties, or have different kinetics. What we know is that, for example, if a CAR T have a CD28 linker, the number of cells can increase really high, but it reduce in a very short period of time. And if you have a CAR T with another structure of the 4-1BB, which is the structure from some molecules that we have in Novartis and Jung Therapeutics, the kinetics is quite different, and you can see the difference between these two structures. There is a not too high, but stay a little bit longer period of time, the period of this CAR T in patients. So we know the structure of the CAR T design of the vector impact on the characteristics of the proliferations and the exhaustions on disappearing of the cells. Some of them are more persistent, some of them are more higher. So that's why we can have different situation and different response in clinical settings. Now, all these CAR T produce a little bit of different response on the immune system. So this is my last cartoon that I will show you, and then I will go through my point of the lecture, which is myeloma and tumors and solid tumors. As you can see here, the CAR T infusions at the beginning, you can do a conditioning of the patient, and you can put the cell infusion, and you can induce to different cytokine response to the patient. This cytokine is not the same. You have different periods or phases. You have an early phase, the first 4 to 5 days. You have the middle phase, and you have the late phase. So, of course, the cytokine profile that is induced in the early phase is different than the second and the latest. At the beginning, you have immune hemostatic cytokines, chemokines, as interleukin-2 mainly. In the middle phase, you have the inflammatory cytokine and some other markers as interleukin-6. This is related also with toxicity. We are going to do some reference about this interleukin-6. By the end, you have different cytokines and some other molecules as granzyme and perforins that increase over the late phase. So this is difference. This has been really related, and also we can do monitoring of the CAR T that we induce to the patients in different settings, different disease, and different stage of the disease. So what happened with myeloma? Maybe you have at the beginning the lecture of the leukemia, which is the major impact of the CAR T therapy over the last couple of years. But now we are having a lot of information about myeloma, which is a disease from the bone marrow, reduce tremendous capability to patients, bone disease, anemia, renal function failure, calcium alterations. Multiple myeloma is a chronic disease. Recently, we have a bunch of different molecules to treat myeloma, but in this field, the CAR T have been a tremendous impact. I will show you some data about that. So BCMA is a B cell maturation antigen, which is expressed in myeloma cells, as you can see here. Myeloma cells have a very high expression of this molecule and can be used as a target for the CAR-T. So this is the vector that was designed for the myeloma, basically direct to the BCMA, which is expressed nearly universally on the myeloma cells. Okay, it's expressed in the membrane. In also this BCMA have a tremendous impact of the myeloma cell survival. So if we can do as a target and if we can do as a therapy against this molecule, we can go directly to myeloma cells and also reduce the disease. I also have to say that not only BCMA is for CAR-T, we just recently have some monoclonal antibodies direct to the BCMA, belantamab, that was just recently approved by the FDA, which is direct to kill and to target this molecule and reduce the myeloma cell activity. So what happened here is the major study that we have for the BCMA direct CAR T cell in multiple myeloma, which is called KARMA. So KARMA was published many years and was updated recently. It's the highest number of patients treated in this trial. It was more than 100 patients. And you can see here the number of prior therapies. As a hematologist, I have to say that maybe many years ago, when we heard about patients with 2 or 3 previous therapy, we'll say, oh, come on, there's a lot of therapy. But now we have different situations, a number of 6 or even more than 10 different therapies before any trial is now become common. So this KARMA trial tests different dose of CAR T cells, and the complete response for this heavily treated group of patients was really high and interesting. I will show you a little bit of this information of the KARMA response. We show you the higher number of maybe CAR T direct to the BCMA can induce a higher response. This is really interesting because in other disease, there is no major direct relationship between the number of cells and the response. But here in myeloma, it's really objective. The higher, the best, but also some other toxicity as well. And you can see here the complete rate response is almost 40%, and the overall response is around 82%. And also for this heavily treated group of patients, the survival is related, as you can see here in the darkened blue, the higher the number of cells, the higher progression-free survival, and also for the patient with a higher complete response is the higher progression-free survival on month. So this shows you that the KARMA trial and this design, this CAR-T in myeloma, will give you an idea that the higher the number, the better the response, the highest the progression-free survival for the patient. There is not only the KARMA trial, there's another trials of the EVOLVE and the CARTITUDE. The CARTITUDE is really interesting because as you can see here, the overall response is almost 100. None of the patient did not respond. So this is really interesting to see how the CAR-T and the development of the different design of the vector and the protocol design can induce higher response in even heavily treated group of patients with many prior therapies before. So myeloma, this is not the end. I will show you here different protocols in myeloma that I'm looking for different design of the CAR-T and also different targets. Here you have the LF7, which is really interesting molecule in myeloma. Also, you have here the BCMA combining with the CD19, and also the BCMA combining with the CD38, which is different strategies that we are using in myeloma to induce a major response. So multiple myeloma has been a very crowded field and different situations to test the CAR T, and also doing combinations, not just for one marker or target, with different targets, and also different strategies to combine with another two different targets, as we see here in this cartoon. So in multiple myeloma, we have some lessons to recall. At first, that we can achieve unprecedented response, up to maybe 100%, complete response up to 80%, and also MRD rate, which is really important in myeloma, down to the -6 sensitive, exceeding 50% of the patient. So very high response rate and the clearance of the myeloma cell in this patient population. Of course, if you compare this with regular therapy, you can exceed multiple times the prior rate in this patient population. So far, this patient population response with different new molecules is around 10 to 20%. Now we are increased almost 100% in most of the patients. Also, there is an unprecedented control of the disease with a progression-free survivals a very long period of time. But as you can see here in the curve, okay, there is very long period of time with progression-free survival free of the patient. Again, this is exceeding multiple times the prior PFS rate in this patient population with different other strategies. But I will say that also we have to be clear that we do not see signals of cures. So these cures show you that you can control the disease very long period of time, but the problem is that you cannot control completely the disease. This is quite more related with the next step that I'm gonna show you some information about the solid tumors. Solid tumors is quite interesting because it's different than the hematological tumors. You have different barriers, and these barriers have been extremely investigated. Many research around the world have been working on this. What are the principal caveats and also the barriers to control? And you can see here this published from the people from Fred Hutchinson in Seattle, Washington. Different situation of the immune suppressive factors that is secreted by the tumor, and also immune suppressive cells that are induced by the tumor, and some other checkpoint inhibitors that are induced by the tumor. So these different barriers, of course, reduce the capability of the CAR T or any immunotherapy to deal with these solid tumors cells. And also to recall you that many of the tumor secrete chemokine that also can modify the CAR T and also produce different response against this tumor. So in this cartoon, I will show you how the CAR T is coming to a solid tumor, which is a heterogeneous group of cells, molecules, and interactions. For example, you have here different ligands, inhibitory ligands, and soluble factors as TGF-beta that can reduce the CAR T response. So in purple, you have for example, in this cartoon, this inhibitory cytokine TGF-beta that really reduce the CAR T response and the activity on this solid tumor. Okay, so we know that solid tumors induce immune suppression, and also the immune response is very low because the different cytokine release and these inhibitory ligands that are expressed in this really complex solid tumor, which is not heterogeneous. Sorry, it's not homogeneous, it's really, really heterogeneous. And this is the way how we have to deal in the case of the solid tumors. Solid tumors, we also have different targets for novel targets, novel therapies as the CAR-T. At first, we have some targets that are related to different cancer types, as mesothelin, for example, is expressed in different cancer types, and here you have different protocols on mesothelin. Also, for example, this New York ISO1, different cancer types are also expressed. Some others are related to a specific disease, for example, CD171 for neuroblastoma, GD2 for neuroblastoma and sarcoma, Lipicam-3 for ACC, hepatocarcinoma, interleukin-13 for glioma. So you have at first in solid tumors the situation that we have targets specific for one tumor, but some other are expressed for different tumor types. So here some candidates are really interesting because you can go over different tumor types or you can do over a specific tumor type. I will show you a little bit about these couple of examples. This is, for example, the prostate-specific membrane antigen. This is developed by Dr. Bruce Levine from the University of Pennsylvania, which is working on the solid tumor CAR-T for prostate. And here is not just the specificity of this CAR-T direct to the prostate, specific membrane antigen, but also armored the vector with some other receptor as the TGF-beta delta. You must remember that this TGF is related with this inhibitory function of the tumor that induced to the immune system. So for the solid tumor, there is a strategy to try to be a little bit specificity, but also to try to put some armored molecules to reduce the immune suppression by the tumor. This is a little bit more complex because currently most of the new vectors used for the solid tumors are now really complex. Here, for example, you have this armor CAR-T, which is with the regular part of the CAR-T, but also a tremendous difference linkers that are related to induce more immunological response. For example, this interleukin-7, which is related with memory, differentiation, and proliferation of the T cells. This CCL19, which is related to migration and homing. This TEGFR, which is related the possibility to control this membrane receptor and reduce, as we do as cetuximab, for example, the apoptosis, and the CCR2, which is related with migration and homing. So strategies to deal with solid tumors are related a little bit of specificity, but also related to armored vectors to increase immune response, because the situation on solid tumor is that this tumor produce immune suppression of the immune response. Also, Dr. Levine is working with this mucin. This mucin, you must remember, is a target for different tumor types. This mucin is related for this glycosylate mucin. This is a normal cell, gastric normal cell. You have the mucin here, which is glycosylated, but it happened in a tumor type cell. For example, this is a ovarian. This mucin and glycosylated is really alterated. This is a little bit of the situation, but it happened. They call it Stumpy, which is very low. The glycosylation is alterated, so you can do direct inhibition of this mucin and try to go directly to this tumor cell. But we recall you, this mucin is not just for the one tumor type. This is expressing non-small cell lung cancer, in pancreatic cancer, and triple best negative cancer, in ovarian, and also in myeloma. So this strategies is related also to try to look different targets that are expressed in different tumor types. So poisoning, which is one of my favorite part of the talk, because we learn a lot with the pandemic. I want to tell you, I want to tell you that here in Peru and maybe in other places, as in your hometown, we were dealing with the COVID and the pandemic situation, which is the cytokine storm. We learned a lot how to deal with this cytokine storm, which is one of the major problems on CAR T therapy. Also, the use of tocilizumab and other monoclonal antibodies against some cytokines that are direct related with the cytokine storm is really interesting, because you have to do monitoring. You have to precede the clinical situation. As soon you are using the CAR T, you have to look your interleukin 6 levels, and it's really easy to do that in the lab. And you can, as soon as increasing the number of the value of the interleukin 6, you can start tocilizumab as soon as possible and try to avoid major clinic complications, because it's really available, the medication in the country. And what we are now doing is to try to monitoring any situation of the toxicity of the CAR T using this really interesting tool, which is an app developed by the doctors at MD Anderson, Houston. This is the CARTux is a really easy going tool that you can download to your mobile and see the grade, the diagnostic, and the recommendation for this different kind of situation. For example, you can do the cytokine release syndrome grade and the recommendation. Also, you can do the neurotoxicity, and you can do grading, and also go over recommendation to try to avoid this toxicity for the patient. So for toxicity, we are now looking really early the cytokine release syndrome, and also looking really early, which is the neurological toxicity, and see that you have to do monitoring previous the clinical appearance of this toxicity. Also, you have to be aware about the long-term toxicities, because many of these therapies can induce B-cell aplasia and hypogammaglobulinemia, and can increase the infections. You can have also cytopenias, very long-lasting cytopenias, more than weeks, and also related with infections. We cannot cure of up to 55 of the patients. In case of that, you have to deal with the infections and work together with your infection doctor, infectologist doctor, to try to cover fungus, to try to cover virus, look at the CMV virus, and look at any other bacteria that can produce infections for this group of patients, and can also produce tremendous problems to the patients. So also you have to see second malignancies. To be honest, I'm not quite sure about report of this. So far, it's not observed yet, but we need more time, more follow-up for the patient, that we have to continue on the clinical trial. So what is on the scope? On the scope, there are some new ideas for the CAR T. One of them is allogenic BMT after CAR T, which is a combo. You can do CAR T therapy to the patient to reduce disease, and then you can do your allogenic transplant. Also, there is another recommendation for people again from MD Anderson that are using the cord blood CAR NK cells, which is a new strategy that is using to this cancer therapy, which is related with very low toxicity and no require a HLA match. Here in the cartoon, you can see how from banked umbilical cord blood, you can get NK, you can do your transduction, you can do your expansion, and you can use it to the patient. This is really interesting because from one unit, you can get cells for many patients and also for the same patient for different times. And this has been proved a lot on B-cell malignancies, mainly lymphomas, mantle cell as well. For example, in this in this PET scan, you can be how the lymph nodes very increasing this patient is very reduced with this infusion. So we learned from Dr. Spal, which is one of the leaders in this protocol in MD Anderson, how this NK is reducing very easily the number of lymph nodes to the patient. Also, we have other ideas on the scope to increase response for the patients that are going through the CAR-T, for example, using hypomethylated agents as azacitidine previous to get the T cells, also to blockade the TNF alpha and interleukin gamma rather than interleukin 6. This is really interesting because you can do monitoring and also reduce toxicity in the case of cytokine release syndrome. Also, you have to do another, which is healthy donor cells as a source, looking for CAR-T that are related with a new concept that we are using, which is a T-cell fitness and T-cell strengthness. Not all the T-cells are the same in your life. Not all the T-cells are the same during your treatment. T-cells is a really high heterogeneity of the T cells. You have the naive, stem cell memories, central memories, and effectors. This different situation of the T cells is not just the CD3, it's a tremendous number of these different markers. As the more stemness, the highest proliferation potential. As the more senescence, there's a very different situation that can not be good for proliferation. So your CAR-T must be optimal if you are going these 3 or 2 first steps of the maturation of the T cells. In the case of this very mature, sometimes to try to produce a little bit of more proliferation is quite complicated. Here you can see the same picture. So the typical manufacturing process of the CAR-T include expansion phase, but as soon as you do more days of expansion, your number of memory stem cells and naive stem cells is very low. So the strategy is to try to look at a possibility to try to look more this group of cells, the naive and the stem cell memory, okay, which is related with a rapid manufacturing. So the shortened culture, the highest number of naive and stem cell memory, you're going to have it. And also, this is going to be related with a high replication and proliferation of the stem cell in the patient. We did some tests in some patients. Here, for example, you have the CD4 T cells in one patient. As you can see here, this is the road, the naive, the stem cell memories, the central memory and the effector, and you can see different group of cells. And here you have the naive and the stem cell memories. This is for CD4, and here you have for CD8. Okay, this is one patient, and another patient is different, you can see. So we have different T cells. So the naive here, the stem cell memory is very low in this patient. Then you have here the central memory, the highest in the effector memory, very low on the final effector. And here the CD4 and the CD8 as well. The highest here in the effector, very low stem cell memories. So what we are trying to learn is that, for example, in this CD4 group of cells, is more related to this part. Here in the CD8 is more related to this part, more mature. Here in this patient, almost the T stem cell memory is very low. It's really, really low. We don't have these cells, and we have more mature cells. If you compare this, of course, they're going to be different T cells to treat or try to deal for any CAR T therapy. And finally, the CD8. The CD8 is different here. You can see more mature CD8, and here the stem cell memory is very low. So what is happening is that in different situation, stage of the disease, also therapies, you can have different T cells, and that's we call thickness and the strengthness, which is really important to try to look for therapies and produce the CAR T. They're more challenging of the road in the case of the CAR T, which is the combination of the CAR T and deal with the exhaustion. What is happening is the CAR T over the time is reducing because appears some other molecules that we are trying to deal. So that's what is happening here is you do a combination of the CAR T and some immunotherapies, some monoclonal antibodies against PD-L1 or PD-L1, which is a really interesting strategy in most of the solid tumors. So the combo therapy with the CAR T and the immunotherapies antibodies, we have different protocols here, the SUMA-6, the platform, the Portia, which is combining these monoclonal antibodies and the CAR T against different disease. The couple of or three trials that I'm referring here is mainly for lymphomas, refractory lymphomas, really aggressive lymphoma, and diffuse large B-cell lymphoma. And for example, here you're going to see the response. This is a patient with tumor relapsing after CAR T, and you do the nivolumab, which is a monoclonal antibody, anti-PD-L1. You can really induce and increase again the CAR T, avoiding the exhaustion of the cells and keeping response to the patient. Also, we have combo strategies, and we are now coming to at the end of the lecture. The combo strategies, which is different situation as the co-administration of these different CAR T, bicistronic, co-transduction, or tandem. You can see here how the co-administration is referred of different CAR T design, for example, to the C19, CD20. We heard a lot of this during the last ASH last year and ASCO this year about tandem combination of different CAR against different antigens. Okay. Also, we have the bicistronic, which is one card with different two vectors, which is going to do different antigens, which is really interesting to try to avoid antigen escape. This is really interesting because sometimes the antigen is not expressed. Of course, the CAR T is very low response. Also, you can do the co-transduction, which is a mix of these two different tools here, which is a cell that are direct to different antigens and some other CAR T related to different antigens, and to induce more response and avoid escape of the antigens and keeping the response. And the tandem is really interesting, which is one vector directly to different antigens. You can see here in the cartoon, which is really interesting here, the process. And also it's a strategy to avoid major antigen escape and keeping the response. Finally, one of my favorite last comments are going to be against how to increase CAR T in the patients by using antigen cells that will augment CAR T. This is really new and really interesting because it's not just for tumor, it's also for virus. And I have to say that this recent publish is related to HEV CAR T, that is as a strategy that is using a procedure that can increase the CAR T by different strategies. And you can see in the cartoon, which is a process related to get cells to the patient. We know that these T cells are modified and express the CAR. We know that. So this is a process that is related to the lab. The new point here is that when you put these cells to the patient, over the time, there's going to be a reduction. This is exhaustion, okay? So how to keep this or how to increase this CAR T in the patient is by inducing as well or infusing as well cells that are expressing the antigen that CAR binds to. This is really interesting because this is a push to keep in the patient the CAR T in a higher rate number to keep the response and avoid the exhaustion and try to uh, uh, keeping the response in the patient. So this is just published in Blood last month, that trying to putting together this CAR T plus cells that are expressing the antigens will show you new strategies that keep the cells in the patient and avoiding the relapse. Plus, another strategy, which is the infusion of anti-PD-L1 antibodies or any other antibodies against immune checkpoint inhibitors that also are infused to the patient to try to keep the response in the case of therapy. So these different strategies are being used for solid tumors, but currently they're being used for some virus, including the COVID-19, trying to increase the CAR T response in case of very low burden molecule antigen in the patient. So this is a strategy that have to be aware about that. There's going to be a lot of new information about this, not just combination of the antibodies plus the CAR T, but also some other enhancers as these cells expressing the antigens that CAR binds to. My final slide is to try to show you that the immune effector cell therapy landscape is increasing tremendously. More than 475 companies are related to cell and gene therapy in US with a tremendous investment over the years, more than 400 cell therapy partnerships related to develop, commercialization, and manufacturing over the last years. So there's new cell therapies in the US, more than 85 new cell therapy in the 2018, and is expecting that by 2025, FDA will approve more different cell therapies over the years, because this is increasing tremendously. Is really related to a different type tumors, type and clinical situations, and combination that are appear over the different therapies that we are using on this case. So get ready for your ride, get your car, use your way, look your signaling, and enjoy your life. Enjoy your ride. That will show you different situations in the case of the how you can use the CAR T, show you about the Machu Picchu. I'm from Peru. We were really in a bad time during this pandemic. I expect you and your families and your relatives are really safe. But now things are coming better in Peru. The curve is reducing tremendously. We have Machu Picchu. You're more than welcome to come here to the country that is becoming safe. And this is a final slide. We'll show you my medical school in Lima, different hospitals that we are working here in Lima. This is my MD Anderson. It was a very low building, but they make it bigger with Dr. Champlin. This is a tremendous center that they are doing a lot of research on CAR T, and I will be more happy to have contact with you. Quite complicated about this procedure, about this virtual presentation, but you have here my email. You can also call me if any new ideas, any cooperation could be appears, we are prone to start all this procedure was stopped a little bit because of the pandemic, but we heard a lot about the development of the CAR T and also the combination strategies in different tumor situation of the myeloma and also the solid tumor landscape. Really thanks to all of you for this opportunity. Well, keep in touch. Thank you very much.
You know, I've been around physicians and hematologists, oncologists for a long time. I've never seen this much excitement among, and these guys don't show their emotion. So to just date myself, my first interaction with Hemonc was in UCLA back in 1982. So I've been waiting for the hematologist oncologists to get excited. Again, I think if I quote the ex-commissioner of FDA, Dr. Scott Gottlieb, his famous saying was that this is the first time in English language you can use the two C words together, which is cancer and cure. That's a powerful statement. With that, I think we are going to talk about something that is very important, but not as powerful as cancer. We are going to shift our program to hair transplant and using cell therapy in hair transplant. The next speaker is Dr. Marco Zahede. He is our Chief Medical Officer. I met Marco about 5 years ago. He has come along big time in understanding cell therapy, from exosome to cord blood to wort and jelly. And the reason I'm mentioning his beautiful wife is with him. We were supposed to go to Hawaii to celebrate their wedding. What they provided in lieu of a wedding was, you know, I've heard the term drive-by shooting, but never a drive-by wedding. So we had a drive-by wedding in the front lawn. With that, I'm going to invite Dr. Marco Zoidy to join the podium and share his thought with us from the hair transplantation and cell therapy or exosome. Dr. Marco.
You've heard a lot today from the osteoarthritis, from Dr. Gupta. You've heard a lot from Dr. Hisham and Dr. Tony on CAR T cells and cancer applications, from Alad on exosomes, and I'm going to really leave most of the detailed science of the exosomes to the expert, Malad. I will build on what he said earlier, just to present a little bit of a science basis for how exosomes have the potential to treat hair loss. The basic science is there. The secretome of the exosome, as he described, is extremely complicated, but it is mapped out to some extent. And so we know that there, whether it be an MSC exosome or a dermatofibroblast exosome, there is a lot of growth factors that can be utilized and harvested in combination with your traditional hair growth processes. Does anybody in the room do hair growth procedures? Just curious. Obviously, Dr. Salas here. Okay, so about 3 or 4, and we lost a couple people at lunch. So we're going to follow this. Dr. Salas, right, is going to follow with some additional hair growth techniques. So let's get started. So I do have some disclosures. I am the medical officer for Invitrix and for Capilli, which I am going to also introduce some of my techniques in combination. And today's agenda, we're going to talk briefly about physiology of hair growth, follow it up with pathophysiology of hair loss, and then we'll dive into treatment modalities using a couple case studies, and I'll answer some questions at the end. So hair cycle growth is well documented. There's 4 phases. You might add a 5th phase to the end of this. Actually, it's kind of more an aberrant phase. So we start out with Antigen, Catagen, Telogen, and we can switch off to a 4th phase called Teleflugium, which we'll jump into in a second. So just basic science here. The Antigen phase is the basic phase of hair growth. Right? So this is the growth of the scalp as we know it from birth all the way up until 40. 90% of your hair is in the Antigen phase. Right? And that involves bulb growth, as you can see here. You can't see, I guess. Hair bulb growth down here at the dermal papilla. This is probably the most important junction here, and this is really where a lot of your platelet-rich plasma functions. It's not on the scale here, but this whole depth is about 2 millimeters. So 1.5 to 2 millimeters. So the first thing I always say to anyone doing hair procedures is don't go past 2 millimeters, because you're kind of going past the area you need to focus on. The hair on average grows about 1 centimeter per month, so not much. And obviously that number declines as we age. This phase in particular, hair follicles can last 2 to 7 years before a new hair follicle is developed. And so let's go through that. So the shedding process, which is probably the number one thing that people come to my office for, my hair shedding, right? Number 2, men crowning and having frontal recession. Are probably the 2 most common. And I will say, probably in the last 6 months, I've seen a boom of hair loss, probably because of the financial, social, and economic stress, presidential, who knows, politics, everything going on right now. So if your hair is shedding, I understand. So once we're past this Antigen phase, we're getting to the Catagen phase, which is a transitional phase from growth to decline. The hair stops growing, the sheath that covers the hair follicle starts to shrink and detach from the dermal papilla. And this is a small amount of hair in this phase, only about 3%. And you'll notice the stage lasts about 2 to 3 weeks. So you'll start to notice within 2 to 3 weeks, often after traumatic events, stress changes, newborn mothers might start experiencing this 2 to 3 weeks after pregnancy or delivery. Car accidents, sometimes I see this about 3 to 4 weeks after car accidents. You'll start to see a transition phase where your hair will stop growing and will actually start to decline in health quality. And then it enters into something called exogen, which is a shedding phase. This is, in younger adults, a good thing. It's usually the birth of a new hair follicle and a shedding process that occurs. In a off-cycle, in Teleflugium, which I don't have a slide for, it's a shift towards exogen in individuals, as I just mentioned, who go through traumatic stress. Stress is a very important implication for hair loss. There's lots of behavioral factors: poor sleep, poor diet, drug use, alcohol use, tobacco use. So whenever I do hair growth consultations, we always go through the physical examination and traditional medical diagnosis before we jump into the fun stuff. The thyroid checks are a part of that too. Anemia checks on blood counts is a part of that. So in the final phase here, the resting hair reaches its terminal position, and I'll show you in a couple photos in the future slides what that looks like under a 10 times magnification using Capilli's Grow Track. And then this is the Telogen phase, which is a resting phase. It lasts about 3 months. This is a phase, as I mentioned, where people start to enter, their hair shifts into a phase that's associated with trauma and different metabolic shifts. And there's actual no hair growth that occurs during this phase. Okay, so let's talk about pathophysiology. Most common in men and women is a DHT mechanism. So little things that you can do at home usually focus on blocking DHT. Saw palmetto is commonly used for this. Topical agents, tea trees are some topical agents that have this mechanism of blocking through various means. There's a couple medications I'm sure everyone's heard of. Propecia is a 5-alpha reductase blocker It basically decreases the conversion of testosterone into to DHT, and DHT is the mechanism that causes delayed synthesis of protein, shrinking of the hair follicles, and some of the things that we saw in the hair follicle stages. So blocking this has been a mainstay. There's been crossover for prostate cancer treatment using finasteride. They do have adverse events, and so there's a newer shift towards using topical finasteride. The efficacy on that has not been well validated yet, but theoretically it should have a lot of similar efficacy. DHT, as I mentioned, hair follicles tend to shrink, blood flow tends to shrink, and these are some of the things that we're trying to reverse using PRP and microneedling techniques. We're trying to stimulate blood flow. This is a typical scale that we'll use for classifying where a male is on hair growth loss, Norwood scale. It's kind of a look, kind of feel thing. It's not super objective in how you get on the scale, but I'll show you some newer techniques and kind of help evaluate that better. So female hair loss is another big thing. I get a lot of that too. Family history is probably the most common. Androgenic is the term we use, even though we can often confer that with males. DHT, again, is the mechanism for family-related hair loss. Hair loss in females, age-related, tends to occur in the middle first, and I'll show you that here. This is the Ludwig scale for females. Hair loss tends to begin along the midline part, unless it's traumatic or stress-related. A second common mechanism of hair loss for females is menopause. The balance of estrogen and testosterone in females is very important for hair growth. And as females enter menopause and the estrogen levels drop, the DHT mechanism takes more effect and leads to hair loss. So some women ages 50 and over you can actually reverse some of the hair loss using estrogen binders and estrogen transdermal creams and so on. The final pathophysiology that is extremely relevant and something we are actively talking about at Invitrix is the autoimmune mechanism. And that is the alopecia areata. And patients often come into my clinic with this condition and they have coin-sized shaped lesions of hair loss. It can be quite embarrassing and quite uncomfortable for these patients because, as you can imagine, oftentimes they've never had this before and they're extremely uncomfortable and scared and not sure what's going on. The good news is 90% of alopecia areata is curable. I'd say about 5% of them are alopecia globalis, which is a severe progressive condition. It does not have great treatment options. Even the traditional alopecia areata does not have great treatment options. So I think that this is a very pivotal place where the exosome might have potent anti-inflammatory potential. The mechanism is not extremely well elucidated, but autoimmune attack of the dermal papilla leads to this type of hair loss in a very undescribed or unpredictable kind of manner. If you might, a characteristic that I see is a patient comes in with a coin-shaped lesion here. We'll treat it with some topical steroid injections. It slowly recovers, and then 6 months later, it comes in another area, and a year later in another area. And so it's very kind of debilitating to patients, and they often, especially females, are very sensitive to this. So today's kind of main focus, I'm going to use a couple devices and Invitrix's exosome products to demonstrate two case studies that I did. One of the case studies is on androgenic alopecia in a male using the Invitrix exosomes and a delivery mechanism of a device called the Morpheus, and I used the monitoring using a Grow Tracker phone device that's a high resolution image, and we'll jump into that. Again, I'm not going to get into the exosomes too much. These are 50 to 200 nanometer coated particles, liposomal coated particles with various messenger RNA, peptides, among other things that are basically a cell-to-cell messenger. And so that's a new paradigm in our understanding of regenerative medicine. Grafting, autoimmune or decrease in inflammation being mechanism number 2, and now cell-to-cell communication being the third interesting modality that cell therapy is known for. Oops, I jumped ahead here. So one of the proposed mechanisms of action in hair growth is an increased expression of growth factors IGF, KGF, and HGF in the dermal papilla. Hair shaft elongation was demonstrated in cultured hair follicles applied with exosomes. Hair follicle neogenesis was also demonstrated, and a conversion from to antigen from telogen phases, which is the phase where hair growth subsides and ceases. And this was demonstrated by a couple individuals here and published in dermatology literature back in 2019. There's a lot of newer publications on this as well. And so it's an exciting field. This is a Morpheus device. This device is a electrophoresis device. You can preload anything you want topical into this. And it will, using a microcurrent, it will infuse this product into the scalp. So this is a needle-free way to deliver your topical products, whether it's Reluma's hair serum or something potent like their exosomes. This whole process takes about 5 minutes and spares the patient from having to go through needles. However, I will say, in the case of exosomes, you do need to use a scaffold. So exosomes are so small, like a virus, it can basically infuse away from the area of treatment. So I treat all of my patients with PRP, calcified PRP. It creates a scaffold, and then the exosomes get locked into that scaffold rather than diffusing away, and they can, over the course of a week, have local trophic effects. This is the Morpheus' microcurrent technology. As I mentioned, it's a non-invasive way to pull growth factors into the skin using electrocurrents. This is the Grow Tracker that we use combined with the software. The Grow Tracker basically is a device that you take photos of the scalp, and using an algorithm software, it preloads on multiple scales like the Savin scale, the Ludwig scale, and it has some pretty cool detailed photos that you can see, and I'll jump into those shortly. So here's one of my more successful cases. I like presenting this gentleman because it was very important for him. He's a young male, 23, and he kind of got some of his life back on track. Prior to, as you can see in the photo, this individual had lots of treatment modalities that we tried. Ketoconazole, which is an antifungal, your traditional Rogaine, minoxidil. We tried biotin, we tried Propecia. He did smoke, so we stopped that. We tried improved sleep hygiene, and we did try standalone PRP injections at a 750,000 platelet concentration. Unfortunately, we did not see success. This is an image using the Grow Tracker of his scalp at high resolution, some of the frontal hairs and some of the more lower density hairs there. We did some density mapping as our baseline to try to get a better understanding of his density mapping, and as well as to kind of see some of his hair follicle shaft issues. And if I can, you can probably see, so this is a typical hair follicle. What you'll see, I have a couple other slides where we'll not just measure the density, but the thickness. This is a terminal hair follicle. It has a different color, usually a whiter color. It's a lot thinner. This is a nice, fresh antigen hair follicle, very thick. And so you can also kind of get a better understanding of what phases these hair follicles are when you look at it under a 10-time microscopic view. So my protocol, as I mentioned, I will use platelet-rich plasma injections. I usually do a ring scalp block or a topical numbing anesthetic for the scalp. This gentleman in particular, we're treating the front distribution and the temples. I usually, as mentioned, do a PRP scaffold. My injections are 1.5 to 2 millimeters. And in this particular study, we used 10 cc's as a higher dose induction therapy for the topical application using the Morpheus. For the follow-up studies, we did 2 sessions, 6 weeks apart. We went down from 10 billion to 5 billion exosomes per treatment. And here is a 6-week post under the microscope. You can definitely see some significant improvements in some of the slides in terms of density. There's some additional sort of analyses in some of the slides that we saw earlier where you can appreciate the new hair follicle neogenesis. This is his analysis when we did the hair growth. as I showed you guys earlier. And this is more important. You can start to appreciate some of the improvements. You get your distributions before and after, and you can see some transitions in the right direction there. And this is a macroscopic view of before and after. And so you can kind of start to see what's going on a microscopic view, and you could start to also see what's going on a macroscopic view, and it all starts to make sense. So here's another case study. That's androgenic. We're switching over to alopecia areata. This is a 26-year-old female. She's a nurse. We failed local injections. And by the way, local injections are very harsh on the scalp. They can cause dermal atrophy. Very often patients with long-standing alopecia areata, they have indentations on their scalp. So I'm really happy to offer these alternative therapies. We did 2 PRPs for her. We did 1 PRP with ACell, which is an organic matrix derived from porcine bladder, which has been used for decades in burn wounds and has beneficial growth factors for hair. We tried Propecia. There's a European study, 2.5 milligrams for females from Europe. That has not been successful. And we did a dietary and sleep modifications. So other photos of her scalp there from different views. Similar, we did an induction therapy with 10 billion particles of exosomes using the capillary Morpheus. Same thing for the post. We did 2 sessions of 5 cc exosomes with PRP, and here's some before and after photos. She came in before I had the growth tracker, so I don't have all the post analysis. And one thing I noticed, once they get their results, then they usually run away really quickly, and they don't come back very often. So they usually run back when there's not success, right? And she's had really good results, and she's really happy, and she's back to nursing. So there's a couple other photos. So just briefly, you know, some of this protocol-driven multimodality is really where hair growth is today. Hair growth has to be multiple modalities. You have to treat people with biotin, vitamin D, platelet-rich plasma, exosomes. And a lot of patients have to be open to that. Transplantation is really the gold standard for hair growth. So it's nice that exosomes have been sort of a bridge between platelet-rich plasma, which has some drawbacks, mostly being you don't get a lot of hair growth, and exosomes have sort of been a bridge towards moving us in that direction towards non-invasive treatment options. You can also inject the exosomes. I know a lot of physicians who do that. Technically the results should be the same. And so, you know, I'm looking forward to possibly one day doing a formal study on this, alopecia areata. And then you could do, you know, a lot of hair growth physicians don't have an objective tracking system. That's really important. So there's some low-cost alternatives out there for photography tracking, so you can be more objective when you present your results to your patients. So, any questions I'll take now. Yes, Sean.
So, Marco, you mentioned that there is a role for IGF-1 and a role for KBF. What of those exist as drugs? Does the actual drug have a role in solving this problem or not?
That's a great question. I think we have to always sort of weigh the pros. He asked the role of IGF-1 and some of the interleukins that are important for hair growth. I think we always have to weigh the pros and cons. I think the pros in that case would possibly be growth factor to the hair, but the cons might be local side effects and adverse events. And I can't say specifically for IGL-1, but I can say one of the mechanisms that was elucidated for alopecia areata is the JAK kinase pathway, the JAK-STAT pathway. And so there are clinical trials for JAK kinase inhibitors to kind of reduce the autoimmune activation, and those have been successful. I think they're in phase 2 at the moment, phase 3 actually. So there's definitely a growing trend towards using biologics, using those mechanisms. But I think what you're kind of doing is reverse engineering the idea here. I don't know if interleukin-1 specifically is responsible for that. It's kind of what Malad said previously. There's a millia of growth factors in these exosomes, and part of the role of the regenerative company moving forward will be to tease those out And that might be one of the solutions there in interleukin-1, which is already commercially available, right, if I'm not mistaken. And then the next step, I think, for any exosome manufacturer will be to really start to define homologous use. How can we potentially treat hair growth specifically with exosomes that are derived from and for hair follicles versus ones that are derived for or specifically for cancer, in the case of CAR T cells and other cancer treatments. I think that will be a very interesting direction that the industry should take. But there's lots of little things in that. And I think the secretome of exosomes from Wharton's jelly-derived MSCs really needs to be investigated further to delineate things that we already use on a continuously common basis in medicine that the exosomes have that we can also start to apply for these special conditions. It might be a good study to do, just the interleukin-1.
Thank you.
Yep.
I have two quick questions.
Sure.
Was that Morpheus the machine made by InMode? That machine?
No, that's a radio frequency. This is a electro. They share the same name, but it's a different.
Oh, so it's a completely different company.
Yeah.
Okay, next. I've seen some hair restoration people touting putting in threads into the scalp. Have you seen that?
I mean, I've seen threads
like
all over now.
Alan Bauman in Florida, he'll put in like 200 smooth threads into the scalp, and he says that helps. I've never done it, but I just wondered.
It's an interesting question. I think it may benefit in terms of the end mechanism of a lot of this being stimulation of local trophic factors, just like a thread. If everyone's not familiar, threads are P.2 filaments that we put in the face to do some facial sculpting and lifting. They're basically inorganic material, but the benefit of it is the body treats it like a foreign body and starts to lay tracks around it. And so maybe perhaps in the milia of that mechanism of growth that occurs around it, there's some potential. It'd be interesting to look at that. It doesn't seem intuitive that it would, but it's
Collagen stimulation maybe, supposed to grow around the thread, maybe that's it?
That's probably one of the mechanisms. I could certainly see it working against you too with the inflammation, the presence of something that should not be there, like a foreign body under their skin, like a piece of wood that broke off. Very often that area is not suitable for hair growth or healing, sticking under the skin like that. But I have done a lot of threads in the face, and it'd be interesting to pay attention to any hair patterns that grow there. And I would imagine if that were the case, we might start to see some lines growing.
I've never seen that.
I haven't either, so I don't see why suddenly it works on the scalp and it doesn't work there. Any other questions? Okay. Well, I'm on time, 2:30.
We saved the best for last. The last presenter is my good and dear friend, Dr. Sarah Salas. I had the honor actually to be in her beautiful facility, and actually we did a couple of cases where we did a liposuction fat isolation in cell transplantation, also cord blood. Again, she's another physician that is really dedicated to her patients. You can tell that from bedside manner and how she really performs, and I really wanted to share that with you, that I really enjoy working with Sarah. Dr. Salas is a well-accomplished dermatologist. She is international in her approach. I think she has trained in Israel. She frequently comes to Southern California to learn every technique that there is, and she's perfecting her game. Again, it's my honor and privilege to invite Dr. Sarah Salas to the podium.
I'm running through the computer. I hope that there's two videos that I want to show you. I hope that is, do remember that I put it in the USB, but let's start with this. Thank you for staying. Being the last is kind of a challenging. I hope that you're not just sleepy after lunch, but I want to start like saying thank you so much, Habib, for the invitation. It's the honor is all mine. I love and I'm so excited about every time that we have this conference. I mean, I learn so much, and I love to share also what we're doing, and also thank you the wonderful Invitrix team. I mean, it's been an honor, huge honor. So, and I love the presentation that Dr. Marco Zahede did, because it leads me to a more easy way of explaining the cases more than the theory. He explained like wonderfully about the major hair loss causes, and it's gonna make more sense what I'm gonna discuss. So I need to click it. Yes. Okay. So, so this is kind of the basic, very easy way of seeing the structure of the follicular unit. And when we talk about the follicular unit, we know that around the epidermis, especially at the bulge, which is the area that you can see there, close to the erector muscle, where we have the most important niche of stem cells in the follicular unit. So, and we know we're gonna, mainly what I'm doing and what I'm gonna show you, I'm not doing exosomes at this point. All the photos that you're gonna see are a combination of Raluma, original product, or cord blood stem cells. Some of them we did fat cells, as Habib said. But 98% of my cases are using umbilical cord stem cells. And then, so we know that the adult stem cells are considered to be able to provide to produce these growth factors. Once we put the stem cells into the scalp, then starting to sense about what is needed and producing the several growth factors. So this communication between the dermal papilla and the niche at the bulge, the stem cells at the bulge, and also stem cells that they're in constant communication between the follicular unit itself, what is happening in the follicular unit, with other follicular units on the side. So when there is a damage, they're gonna activate the growth factors and they're gonna fix it. They're gonna fix the skin, they're gonna fix the follicular unit. If the unit or the skin, there's a lesion or there's some damage. Now, the epithelial lineage in the skin are maintained by stem cells, and it's gonna produce again all these growth factors. In particular, the hair follicle stem cells within the bulge region of the follicle promotes continual and repetitive regeneration of the follicle during the hair cycle. So Mark explained the importance of knowing the stages in the hair cycle, the anagen principally, the anagen to catagen to catagen to telogen, and he explained wonderfully, like, I mean, how it lasts and how many hairs do we have in each stage. So there is to talk about stem cells into the scalp. I mean, we have the huge advantage that the access to the scalp is very easy. I also do a rim block to make it really, really, I mean, not painful at all. It's not invasive. You receive the same day that you're gonna apply the product, you receive from Invitrix, you receive your vial, and then you defrosted it, and then you apply it. It's so easy to do it, and it's not invasive, and there's no downtime, there's no recovery time that the patient should, I mean, avoid certain things. Just that day, I just tell them to just not to do like exercise that day, and the following day just normal activities. And again, it will depend on the kind of stem cells that you're gonna use. If it's a cord blood stem cells, it's gonna take you like 20 minutes to do it. If you're using from fat cells, of course, there's need to be to a process of obtaining the stem cells from the fat tissue. So some of the benefits of the stem cell in hair restoration, the hair becomes stronger and thicker. We can stop the hair loss. We grow more hair because the hair follicles asleep are forced to pass to anagen phase, which is the growing phase, and also the cells can regenerate the skin, the follicle, and you can use the stem cell in combination with medical therapy. We tend to evaluate, of course, every single patient, and then rule out, as Dr. Zahede said, about ruling out any vitamin deficiency, hormonal imbalance, and then we check what are the genetic predispositions that the patient may have, or also to rule out any autoimmune disease. So once we establish which diagnosis the patient has, then we can put on the table what are the options. Are we going to do medical therapy? This patient is going to be a candidate for stem cells, which for growth factors and stem cells, 99.999 of your patients most of the time in androgenetic alopecias, and in the near future in autoimmune diseases that also can be a candidate after the inflammatory phase is settled, and can be a candidate. Also, I put you here, SMP stands for scalp micropigmentation because it's another camouflaging technique that you're gonna see, but it's something in the meantime that will regrow in the hair. And also I do it in combination with hair transplant, because we know that all these, what we're seeing is that when we're doing in combination with hair transplant, the grafts starting to grow faster at 2 months instead of 3 months, where that is, or the normal like growing scenario for the patient. And also what we're like seeing in every single patient is that the anti-inflammatory effect, it's like I couldn't see the difference, like at least like 5 years ago that I started doing it, the difference between the inflammatory phase that is like way better, less, when I combine it with stem cells. The production of the scabs are way less, and the growth of the grafts are going to grow in a faster way. So there's several articles that proves that stem cells or the conditioner media, adipose stem cell conditioner media works to treat hair loss diseases. Here there is this is an article that proves that it was working with alopecia areata, and I did IV application on these patients, and they had, in this article, they did 9 patients, and then this is one of, their best patient that responds, with this therapy, and the result was, they follow this patient like 2 years after, and she remained, she kept the results. So there's several articles that proves that all these factors that we're talking act directly into the anagen phase, or stimulate, activate the hair cycle to a more accelerated way, and also stimulate and induce the hair follicles to go to the anagen phase, which is the growing phase. In this article, they did these 27 patients with androgenetic alopecia, and they treat with adipose conditioner media once per week for 12 consecutive weeks. And what they saw in every single of the patients was like an improvement in the hair thickness and the density. And the way that they did it, it was like in combination. They put it like topically, but they did the roller. This is the photo of the article. It's like contains like tiny needles. So they did that as a way of delivering the conditioner adipose cells conditioner media. So if you have a patient like the photo, and so there are different things that we must rule out, as I said, but we can see here. If the patient is having hair, you're seeing hair, this is a patient for growth factor, for exosome, for stem cells. If the patient doesn't have anything, don't waste your time there. I mean, the only option will be hair transplant. So these are some of the photos of the article where they prove that the patient, got the results after their therapy. So we can see different articles that they prove that all these growth factors helps with hair restoration. That's why, for example, in this one, they did a trichogram on the patients, and they followed this patient for 7 months, and they couldn't see a difference between not only the number of hairs, but as you can see also the thickness of the hair. So this encourages, and give us the information to give to the patient that what we're doing is scientifically based. So these are more photos, and as Dr. Marco said about the classifications, we need to classify, of course, our patients, and for the Hamilton one for the male patients, or Ludwig for the female patients. Now, when we are having these kind of patients, if the patient's having miniaturization, meaning that this combination in the scalp of thick hair with very baby hairs, that means that in every cycle the hair is becoming thinner. There's something that we can do about it. Another thing that we are looking is to, especially in my area that I do a hair transplant. If I have a good donor area, I can do whatever I want. But there are some patients that when we are doing the trichogram or we're doing the microscopic analysis, we can see also a lot of miniaturization in the donor area. So we need to see what else we can do to reinforce the donor area, and there's something that we can do. Every time that I'm seeing also a thin process going on in the back, besides ruling out vitamin deficiency or other problems that can be happen in the same scalp, I do need to do something. So again, stem cells will be something to reinforce the donor area, and then the patient that was not a very good candidate for hair restoration, then we move them to a category of being a good patient. I like to show this photo because when we're planning what we're gonna do, we always analyze the donor area that we have. What are the potential, especially with young patients? What is the family history? If the patient is having a family history of a normal Hamilton 6 or 7, and it's very, the patient now, we're having patients 17, 18 years old that they want to do anything to get rid of the temporal, so they're starting to recede. Those patients are not candidate for hair restoration, are candidate for medical treatment, are candidate for stem cells, exosomes, medical therapy, but not for hair transplant, especially if we ask and we find that they have a genetic predisposition to have a more advanced hair loss process. So also, there is a hair loss problem also, not only receding here, but also there is one that the name is retrograde, that is starting from the occipital area to up. So if we are treating patients with hair transplant at a very early age, where we are not seeing that miniaturization going on at that area, and we evaluate that is a safe donor area, so there's a lot of things to analyze before taking in consideration if the patient is going to be a hair transplant patient. Now, these are this is a patient only with growth factors, the Reluma original formula. And this patient, this patient had a very good donor area. This patient didn't want a hair transplant. So again, one are the things that we can put on the table, like the options, and then of course the patient make the last decision. So this patient never wanted hair transplant, so I said, okay, I will leave you with medical therapy. And of course, I mean, starting to have a very good response. As you can see here, it took us like 5 months to get to this point, and it's not like a surgical result. You can see some thin areas at the crown and in the frontal hairline and mid-scalp, but it is way better like the way that he was. So he was very happy, and we keep him with the medical therapy. So here is like a view from the side and the crown, which I think was like really, really good. So as I said, we must have some hair. If you don't have any hair, there's no role of putting this patient on growth factors, Reluma original, or stem cells, or whatever. We're not gonna grow from nothing. Once the follicular ostia is closed, once it's like shiny, there's nothing that we can do, only a surgical procedure. But, for example, there you can see a lot of hair, but it was so tiny that I didn't give him volume. So we add the growth factors, and we started to see a very, very good result. Now, this patient, for example, is a 19-year-old patient that's with family history from both sides. Mother and father with huge problems with the hair. So of course he started at 18, noticing that something was happening, a thinning process was happening on the entire top part of the head. So we start with growth factors, and then he was like, well, is there something faster? Is there something better? And I said, well, yes, stem cells. So we did this patient, and this was his results with one stem cell therapy. Now, again, we're looking at the first photo, and the patient has a lot of hair. Of course, it's going to make sense that he's going to respond. And what we're doing after we have this, then the patient needs to continue with the medical therapy or with the applications of the stem cells. Why? Because under genetic alopecia, we're not going to cure it. It's like predisposition. We're not going to fix his genes. I mean, not at this point. Maybe in the future they will develop something, but not now. So we need to keep up with the result. What I do is that the regimen that I normally follow, it's like the first treatment, then at 3 months, then at 6 months, and then once a year. All the patients, and I run lab work before. I make sure that I'm not missing anything. I'm not leaving, I need to check everything because I need to guarantee to the patient the result. So every single patient is going to respond. It's going to take you just one patient to really see the results, but agree with the patient to continue with the treatment for 3 months, because it's impossible that in 2-3 weeks you're gonna start seeing the hair coming out. Why? Because the hair cycle, you need time to do that. So and that's something that we need to talk at the beginning. So this is another patient of a stem cell. So we can start to see that the tiny hairs are getting thicker, are getting darker, and we're starting to fill the spaces. Again, just one treatment, 5 months after. We're starting to see more the crown area. And one of the things that you're gonna see is that the periphery is gonna shrink first, And then the last thing will be the center, because the center is the more affected area. So that's what we're gonna see, and that's what we're gonna explain to the patient. And this is another patient, very, very good candidate for hair restoration, but he didn't want to. So then we started with stem cells, and you can see a lot of regrowth and a lot of thickness. Again, it's not the hair transplant result, but it's way better than he was. This is a patient that had a female parent hair loss, and we started with stem cells. And all the patients, if you choose carefully your patients, and again, you need to know what to rule out in order to choose which patient is going to be a good candidate for stem cells therapy. And then these patients are at 3 months, that normally I see them at 2 months or 3 months after, or 3 months for the second procedure. And she's starting to notice, of course, a more thicker hair, more darker hair, and especially for us, as we tend to lose our hair in a more diffuse way. And so you're starting to have a lot of tiny hairs that later we can comb it, and then but it's like all over. Now, if we're gonna treat, for example, this patient, we're gonna treat her in the entire toe part. I'm gonna put the nerve block, a rim block in the front, and also below the crown. And I'm gonna inject the entire toe part. And also I noticed that the stem cells, has a cascade effect or domino effect. So I can see a reinforcement of the donor area, which is gonna be very important if in the future I want this patient to be a candidate for a hair transplant. Here is another patient, one before and after, 3 months after one stem cell therapy. So definitely, you don't need to do a microscope evaluation. The patient is starting to be like crazy happy, and we can see that we're starting to feel like all those empty spaces, and to make it more thicker. The hair is gonna be more thicker, and again, the area from the periphery are gonna reinforce it first, and then the last part will be the middle part, which is the area that had more the miniaturization. And so you can start to see how we're feeling this area, and from the side also. And let me show you video where you can see that all the hairs, like different lengths of hair, you're gonna start seeing. So then the patient started to complain, oh, but now I can comb my hair. And then I was like, oh my gosh, don't say that, because what we want is the hair to come out, and then it's gonna grow, and then you will be able to comb it. And they were like, okay, but we tend to want everything, right? So then you can see all these hairs that, of course, are new hairs because the hair of the patient is long. So, and in a lot of cases, the hair that is regrowing is darker than the other hair. So for example, patients that have white hair, they will have darker hair, and some patients, of course, we all love that. I'm having my stem cells also not to dye my hair, I'm not dyeing my hair. So you can see here, like all that hair with different lengths are the new hair that is growing. So this is important that the patient, sometimes, we said, oh my gosh, how do you, I always ask them, do you think that is working? How do you feel? Well, not really. And I was like, and then I always take photos and video. And then because they tend to forget how they was it, and they were like, oh my gosh, is that me? Is that me? So that's important that you take photos of that. So And then when they comb their hair in different areas, they can see like the tiny hairs like growing and with different lengths, and they're like, oh my gosh, that's true. So you must check that in photos, videos, and check it with the mirror in front of the patient. Now this is another patient. We did this stem cell therapy combination with SMP, scalp micropigmentation, but you can see a lot of volume, and the hair is starting to have, again, we start with a patient that has a lot of miniaturization, a lot of hair. So there's something to grow. This is a very challenging patient. This is a patient with hypothyroidism. And when I started like working with her, she was 43 years old when I started with her. And the entire scalp was like that photo. So of course, the only option for her, of course, was to send her with endocrinologist to fix that thyroid problem, and also started with some stem cells. Hypothyroidism is one of the hardest one to regain the hair, and is very slowly. If we can make it, it's gonna be very slow, but we need to try it. In this case, it was like way better as she used to. So you can see here, 43 years old. And we did stem cells and SMP. Now, this patient, again, it's a patient that I wanted to move to reinforce the donor area. The donor area was having also miniaturization. So I said, this is not the time to do a hair transplant. So let's work first with nutrition, with the growth factors and the stem cells to reinforce the entire scalp. So we start with the therapy, and you can see how the thin area starting, that has like a lot of tiny hairs starting to increase the thickness of the hair. And also we can see that the periphery of the whole thinning area is starting to become more stronger and to close in this concentric way. So again, here you can start to see how all the periphery is starting to shrink. And this is 4 months after the second stem cell application. This is a very young patient that was having miniaturization in the frontal hairline, mid-scalp, and crown. I don't know if, should we turn this slide more, or you can see? You can see? Good. So and we started with the stem cell therapy. Again, the sooner you treat your patient, the better, because we can regenerate more hair than if the patient is wasting time. Like this patient, very young patient, very good result, as you can see here, and it's just one cord blood stem cell. So the temporal recessions, the younger the patient, they don't want temporal recessions. They don't want a recede, and we all want to recede. So we need to explain that too. And this is a female patient that we started with stem cells and growth factors. You can see here how the Christmas tree pattern that we used to have female pattern is like this, like a Christmas tree pattern starting to feel. And with this patient, we decided once we starting to have a very nice result, and then I said, well, let's treat your eyebrows. And then she was like, really? And then you will see the photos after. And this is she, and we're starting to, because she got so excited about the result that she was having on top. So we're starting to do the eyebrows, and you can see how, especially in the eyebrow, we have the head, we have the body, and we have the tail. Especially around the head, look how thick starting to show, and the patient didn't trim, her eyebrows, so you can see like below here in both sides how it's starting to grow also. This is per eyebrow, and you can see like the regrowth that we're starting to have. Okay, again, temporal recessions. Now the temporal peaks. Most of the time when we do hair restoration, and first when we're evaluating a patient and we're seeing if it's just the frontal hairline, if it's a temporal recessions, what is happening, or the crown. But the temporal peak is an area that is very important, that the patient is going to put the growth factors at the temporal peaks, or we need to also put stem cells there if we're seeing like the patient is having like also thinning process and miniaturization going on the temporal peaks, because it frames our face. So that's why it's so important to restore that area and take it in consideration when you're doing your evaluation. So as you can see, like starting to be more darker, and so in this patient are gonna need, even if the patient needs like a hair restoration, like hair transplant on top, he's not gonna need it on the temporal peaks, which is an advantage. Now, this is a very, very young patient, also with a hormonal a problem, and the whole head, she was a model, and she was like so crying every single visit. So then finally, we were starting to see like the results, and that, she was laughing that she was like, yes, I started to see the result. But these are the kind of patients that we want to start with the stem cell therapy right away. And then you can see the crown, how it's starting to feel. Again, the patients that are having hormonal imbalances are going to be slow responders compared to the rest of just the genetic predisposition. This is she like before and 8 months after. And you're starting to see a lot of hair growing. Now, when we do in combination with hair transplant, we do all the different techniques, strip method, FUE with short hair, or FUE with long hair, which is the latest technique. And again, I tend to evaluate the patient and let them know that all the advantages of having the hair transplant with stem cell therapy. Now here we did this patient with fat cells, and because the patient was having also liposuction, and well, we killed 2 birds out of 1 stone. And so we did the hair transplant, and we reinforced the entire scalp with fat cells, stem cells. And one of the things that I like to see is the reinforcement, as I said, of all the periphery. And as you can see below here, we didn't transplant that area, and you can see how the area is starting to shrink. So the patient is going to have a regrowth of his own hair, plus the graft that we place in the most needed areas. Again, you can see here below how this area that we didn't transplant didn't show up in the first photo, and now is regrowing. Now, this patient with a lot of miniaturization, very young patient, 41-year-old patient, we decided to do a hair transplant, but because of he was having a lot of miniaturization, I said we must combine it with stem cells. So we did the design. With this patient, we did an FUE with short hair, and we did 6,000, a little bit more grafts, and we did a high density here, and this is 1 week after the FUE, follicular unit excision, and this is 1 year after. Now, pay attention to the donor area. In hair restoration, it is equally important the way we leave the hair, of course, with natural result, irregular pattern and everything, density, high density, that. But also how we're gonna leave the donor area. If this patient, we already removed in this donor area was minus 6,700 something grafts. If we didn't combine it with stem cells, that number of grafts, most of the time is gonna look a little bit thinner, the donor area, because we harvest so many units. But if you do it in combination with stem cells, the donor area 1 year after looks way better than the previous one. Plus, the regrowth on top, of course, of the hair transplant. So how this patient is gonna keep up with the result, we're gonna keep doing once a year the stem cell therapy. So again, now, patients with poor donor area, stem cells, stem cells, stem cells. If not, I don't touch those patients because they're not gonna be happy because I don't have enough donor area. And so, for example, this patient, he came to me because he wanted me to fix the scar in the middle. He had a motorcycle accident, and I said, "Well, your donor is not very good. As you can see, all the crown. I couldn't touch that area, and below you can see how." The tiny area it was thinning also the occipital area, and the area to receive the transplant, the recipient area was very large, and I said, "I just can't put graft in the line because you're gonna look like a punk." I said, "I need to distribute the graft that you have in all the area," and the area was very large. So, so I said, okay, so let's do like a 2,000 grafts surgery plus stem cell to reinforce the donor, and then 8 months or a year after the first session, let's reevaluate and let's see how many grafts can we harvest. So he agreed, and you can see here how the donor area was 1 year after. This donor area was already minus 2,000 something grafts that I harvest from that donor area. So now having a better donor area, as you can see here, a thicker one, and even notice like the thin area at the lateral humps that it was thinning also, how we can, we got this very strong donor. Now, below, look how strong my donor area looks now. Even this area that we didn't transplant looks way thicker. So now after this result, we decided to do another. This is the first session, and this is 5 months after the second session. The final result in hair restoration always gonna be 12 to 14 months after. But it was like this patient flew from far, so it was like 5 months after. So that's the thing, when we can reinforce with stem cells the donor area also. Now, this patient had also a car accident with 40 surgeries before. I was the 41. They reconstruct the entire face, and they always put the prosthesis and everything for the face through a coronal incision, and it was so hard with a lot of hard tissue, and he wanted to have, also he was having an androgenetic alopecia. He wanted me to have to do a hair transplant, and so we decided to do the hair transplant. But as you can see, it was a lot of hair to make it thicker, so I combine it with stem cells. So in this patient, what we did is we combined 3 therapies. We did the hair transplant we did the stem cells, and we did, here you can see the scar in the middle, that it was like crazy. The entire skull was like a rock. And on the sides, we did SMP to camouflage the scars and to avoid putting grafts there and to put it on top. So I did the SMP there, and this is the other side. This is the before and right after we finished with the SMP. And so here you can see this is 1 year after. You can see the scar that it was obvious on the sides. We did the SMP just one session, and then we did hair transplant here to add density in all the top part, and also we are keeping this patient with stem cells, in order to keep up with the density that we leave him. So this is, we always, take care of an irregular pattern that is going to be like natural result and that, but this is something that a lot of the times we need to combine whatever therapy you used to do, combine it with stem cells or with growth factors, and you're gonna, by far, you're gonna have a better result. Now, one of the things that I love is that for example, the original formula is not greasy at all, so you can. I always leave it in the morning, and it's not greasy at all. So now, look at the donor. I can, in the future, if the patient needs like another one or something, I can do another hair transplant for sure. And also, we plan to do some harvesting in order to put it like definitely hair on the scars on the side, because we didn't, we did SMP the last 5 years. So in the future, we're gonna, once he get rid of the SMP, we're gonna do the hair transplant there. So now, in summary, with the stem cell treatment, the hair becomes stronger and thicker. We can stop the hair loss. We can help our patients in a faster way with the medical therapy. It's a non-invasive outpatient procedure, and we can apply it by itself, or using in combination with medical therapy, scalp micropigmentation, or hair transplant. Stem cell will play, of course, as we learned today, it's playing, and it's gonna play a very important role in the future, in the future cell therapy, for wounds, for hair loss, for many other applications that we're like learning today. So thank you very much for your attention. Yes.
I do have a question. In your Dr. Salas, in your presentation, you indicated that you use stem cells derived from adipose tissue and also derived from the umbilical blood cord. And in my opinion, the effectiveness of stem cell treatment is largely impacted by the vibrancy and by the replication rate of the cells. So have you seen differences if you use stem cells derived from adipose versus stem cells derived from umbilical blood cord? That would be my first question. Okay,
well, it's a very, very important question, because for all of us, what we want is the easier, the better. We know that I'm not a plastic surgeon. I'm not doing the liposuction. The plastic surgeon is doing the liposuction. They give us the fat, and we process it. Now, the time is different. Now, the thickness of the stem cells that they give us, is thicker than the ones that you receive from the vial, which is very easy to apply. So just from there, that's why I tend to like way more the cord blood stem cells. That's why 98% of my patients are from cord blood, and I can and it's so easy to predict. When I'm gonna see the results. So I didn't see like a difference between fat and cord blood stem cells. But again, the majority of my patients are cord blood. So it's like we need to really like run a lot of cases in order to really kind of see in a greater scale if there is a difference. The majority for me, as I said, are cord blood stem cells, and the two patients that we did, for example, with FAT was patients that they were like having also hair transplant. Another one was not having hair transplant, just hair, liposuction for aesthetic purposes, and we use the fat to put it in the scalp. But I'm not. I didn't see any difference between the response of one or to the other one. And you have another question?
Yeah, we heard about the great benefits that exosome can play in regenerative medicine, and so the combination of exosomes with stem cells. Do you have any experience in this area?
No, not yet. Yes.
Quick question. In terms of actually procedure, do you use the microneedling or do you inject?
I inject. Just it.
Inject.
Yes, I put a rim block, and then I inject it. Mm-hmm.
Any numbing cream or?
What happened is because I tend to put first numbing cream because I don't like it. I mean I use a cannula to do my rim block, but I don't like even that they feel I use a 33G needle to put the points of in the anesthesia where I'm gonna use the needle to open the hole to use the cannula. So I always put the anesthesia because I don't want them to feel anything. So and then I use cannula. So I put the rim block, and then on the back, if we're gonna do also the crown, and they don't feel anything with that. So that's why I can inject it very easy.
Thank you.
Yes, Dr. Marco.
How soon between your cord blood injection do you start to do your transplant?
Okay, if the donor area is good and the patient, I'm not gonna fix any vitamin deficiency and they're ready to have a hair transplant, I will do it the day of the hair transplant. If the patient is having a nutritional or hormonal imbalance and the patient, I tend to wait a few months because I send them to the endocrinologist or I leave them with the supplementation that they need, or if they're anemia, my graft are not gonna grow. So the approach is different. So if the donor is poor, then I tend to do 6 months of 2 application of stem cells. The first one, the 3 months, and most of the time, like at 6 months, to reinforce the entire scalp, and then can offer a better hair transplant session to the patient. So it will depend on the scenario.
That was my second question. Are you, in addition to targeting the donor area, also are you using it to target the transplant area to prepare the transplanted hair?
No, if the donor it's very strong and I can see that there's no problem in the donor area, there's nothing to fix, nothing to do with the donor area. We just do the hair transplant. But if the patient is having a lot of miniaturization and I need to fill a lot of spaces, so then I said, well, you must know that this hair, we must continue doing something. The hair transplant is gonna stay there, and we know patients that they had a surgery, just a surgery, without a medical therapy, and then they tend to keep losing their hair, and now they have only the hair transplant, which looks terrible. So again, as dermatologists, we must master all the medical treatment in order to give the 2 options to the patients. That I can give them the surgical approach, but also the medical therapy that they're gonna continue having after the hair transplant. My pleasure. Yes.
The first one, where do you inject? Do you inject intradermal or subcutaneous or subgallal?
No, intradermal. Yes, intradermal.
And then you do multiple punctures, correct?
I'm sorry?
Multiple punctures.
Oh, yes.
And is there a target cell dose that you use, or how, or basically what's the target component of the cord blood cells that you?
Of course, we tend to want. I mean, we in the diagram that I show, we know that the bulge are like at the dermis, and can be also touching the subcutaneous tissue. And so we want to target like that area between the papillary dermis and reticular dermis, and we want to reinforce all that area and really stimulate the stem cells. And I love Dr. Kaplan's last year talk about having all these intelligent cells like sensing the area of what the follicles needs. And so what I explain is that if the stem cells, we put it in the area that need it, and the stem cells is gonna face of follicles that are weak, that are miniaturized, that once I rule out again, that they don't need anything else but to reinforce that it's a genetic predisposition only. So the stem cells are gonna sense all the growth factors that they need to produce to accelerate those hairs, to put them again to the anagen phase, and they're gonna start like growing more towards a thicker phase. So that's why I want to hit that area to reinforce the entire thing. So I go like half an inch, and I in all the area that is needed. If I need to do also for the donor, I do like a rim around the area, and in order to have a domino effect and to reinforce also the donor area.
Do you target any specific cell concentration or number per area when you inject, or it's just basically you divide the product?
Yeah, divide the product. I would recommend you 2 cc's if we're gonna do from the frontal hairline to the crown. That will be enough. And then I do again the first one, then at 3 months, then at 6 months, and then some patients are like, no, in 3 months, because they got so excited, and some patients, for example, these young patients that she was so concerned about, especially in the hormonal imbalances that we know that it's gonna take us more time. So then you can evaluate if you're gonna do it in 3 months or you're gonna wait 6 more months to do it. And after 6 months, I tend to see them like every year for a follow-up application.
Thank you.
So my question is the anesthetic that you're using, are you using ropivacaine or lidocaine?
Lidocaine with epinephrine.
So I've heard that lidocaine can also kill off the stem cells. Is that?
Well, if you put the rim block, you're gonna put it below the frontal hairline, and I mean, you put it with the cannula, and it's not a lot that you use, and you're going directly into the nerves. And then I tend to put the plastic band here in order to prevent any swelling or on the forehead and that. And then I do the application. I mean, I never seen.
You don't see any
and you know that it's less painful to do that in that way. In hair transplant, we tend to do the lidocaine with the epinephrine with a bicarbonate to buffer the pH, and then in order to avoid the stinging sensation that the patient may have, and to give a better comfort to the patient in terms of the experience that they have. And then we put on top bupivacaine, I mean, for long lasting time. But for stem cell application, I mean, it's gonna take me 20 minutes, 15 minutes, so it's not worth it to put like bupi. Mm-hmm.
I can ask it. Sarah.
Yes, Gail.
When you're not doing FUE or strip, and you're just doing, let's say, stem cells, and you get a good result, do you tell your patients prior to that first treatment that they're going to need more stem cell treatments?
Always.
And do you tell them about a year, every year you're going to have to do this?
Always, always.
Okay.
I always write it down. These are always what I'm following. And I said, if you're gonna have a treatment with me, I ask you to give me the opportunity to work with you for 3 months. And then we can make any changes. So, and the patient needs to commit, her himself to the treatment, because we always, of course I want them to have a result in 1 week, but we know that the hair cycle isn't gonna happen in that time. So that's why I said, and I explain with the diagram, and I write it down, the first one, the 3 months, the 6 months, and then once a year for follow-up. And there's no problem at all.
Like I'll have some patients that get a great result, it looks amazing, but then close to a year later, their hair starts to thin again. And I tell them, well, we got to do the stem cells again. And then sometimes they're, well, how many times do I have to do the stem cells?
I said for the time that you want to keep with the result, because we're not fixing your genetic predisposition. We are helping your hair to become thicker, but we're not fixing the root of the problem, because there's no, till this day, there's nothing that we can do to fix that genetic predisposition. So I said always, like in kind of a funny way of, when you get tired of having that hair, then you leave the treatment, they're like, no. I said, well then, you have the response there. They're like, oh yeah, that's true. And I have those patients also that are like, am I going to come back again? I'm like, well, if you want to keep with the result, yes. The good thing is that we can have the result in terms of one session. So that's why it's not like, oh, in how many sessions I'm gonna see the result? Like in 14. I was like, what? No, it's just take you one patient that you try it, and then and in slower responders, I will say, okay, we have a response, and I tend to let them know, for example, if the patient having a hypothyroidism and a prolactin problem or something, that the response is going to be slower. So then I ask them to wait until the second application of the stem cells will be in 3 months in order to really reevaluate. So it will be a period of 6 months they're going to work with me in order to, but I always let them know exactly what is going to happen, always. Any other question? Thank you so much. Thank you, Habib. Thank you, Eloise. Thank you, all the team.
This concludes our 2020 Cell and Gene Therapy Conference. I would like to again thank all our speakers today, Dr. Gupta, Dr. Hisham, Dr. Milad, Dr. Carrasco, who was kind enough to join us online, Dr. Zahede, and Dr. Salas, of course. And most of all, I would like to thank all of you for joining us. COVID makes it really challenging to be here, so we truly appreciate you being here. Tomorrow, by the way, we'll be having our customary brunch where we'll be cruising the bay while having brunch. We'll be departing, the boat will be leaving at 11. If you guys can be here and before 11, we'd love for all of you to join us. We'll be back by 2 o'clock, which, by the way, is early enough for us to be back home and watch the Lakers win the championship tomorrow. So, again, on behalf of Invitrix, I would like to thank all of you for joining us, and we hope to see you all again next year. Thank you.